So now, just before we head into that tea, let's have something to keep us awake. We've got a really sick patient over here, and we put lots of devices into them, and they're all expensive, and they all generate numbers, and sometimes are they really necessary? So one debate that comes up is, we all transduce the arterial line. We're very convinced that that's a really necessary thing. But do we really have to spend another 250 rands on a transducer for the central line? And does the central line transducer really make a difference to anybody, or just add noise? And there's very vocal opinions on both of those things. So we're going to have a debate. And we're going to have Dr. Fulton, our cardiothoracic surgeon, proposing that it's a pretty good thing to do. And we're going to have Kath Mardon saying, hey, maybe not. Now, this is a very focused debate, so it's not going to take long. The way it's going to work is that each of the proponents will have 3 minutes to state their case, alternate, and then 2 minutes each for rebuttal. So it's not going to take a whole long time. They've got to get their points out there. So we look forward to it. And in the end, remember, these are, whatever the outcomes are, these are points. Both will have valid points and things that we can learn from and learn to apply them in the patient that you have in front of you. Okay, so Kath has a box. I'm not sure who's starting off here. You are, right. Here we go.
Thank you, good morning. Lovely to see you guys. I'm going to be doing central venous pressure line transducing. Okay, so historically, yes, we used to use a CVP value just to look at preload and pressure in the right atrium and then determine whether the patient needed some fluid. And then we'd think, okay, if it's high, CVP is high, then the patient is overloaded. If the CVP is low, then dehydrated. So if it's low, then we'd give this fluid challenge and we'd try and figure out how much to give and what the response is and what's the reading. And so it was pretty complicated. And I must say, in 22 years in the ICU, I think I've seen people use it once or twice, the actual algorithm, and use it effectively for a patient. So it wasn't really reliable as a help. And actually, us doing a passive leg raise was quite useful to know what their fluid status was. Have you heard of Starling's law? Sorry, not Stalin. Okay, so he's talking about muscle stretch of your heart, basically. So if it's over distended or overstretched, your walls can obviously be floppy. You put a whole lot of volume in, overload the patient, but the CVP value doesn't go too high, or it's not very responsive. If you've got really stiff walls, you put in a little bit of volume, and then you get this high pressure, and you think, too much volume. Meanwhile, the patient's actually quite dehydrated still. So we'd rather look at arterial response for our volume decisions. What about our valves? What if you have an incompetent valve? See there? So your CVP value won't be reliable there, so you'd look at your arterial response rather. What about inotropes? They make you shunt. Okay, so then you've got this increased pressure, but is it a thing to help you with your volume, knowing how much volume to give? Okay, so it causes a change in your SVR, your preload, and your contractility, so not very reliable. Then you've got your intrathoracic pressures that are increased with your ventilator, and, well, not just your ventilator, but that's one of the things that you can have that increase your intrathoracic pressure, and intra-abdominal pressures, those can be high. And then your values become high unreliably, because it's not about the volume, it's about the pressure. Thank you.
I'll stand on this little soapbox here, make myself a bit taller. The debate is obviously completely miscued. All the things that Kath mentions are valid in general ICU. are totally invalid in cardiothoracic surgical patients and in patients that you're looking after in the ICU, the critically ill post-cardiac surgical patient. And the reason is simple. We're operating on nobody with a healthy heart. So if you don't measure what you do, you have no idea what you're doing. And I've heard people saying they just know. I don't just know, and I've been doing this for a long time. I need all the help I can get. So CVP, central venous pressure, we all know that. Normal is 3 to 7. It's a surrogate for right atrial pressure. And I heard the term floppy atrium. Now, there's no such thing as a floppy atrium. There's a compliant empty atrium, and there's a distended full atrium. You need to come and look at an atrium in the operating theater and see. They are not floppy, okay? If they're empty, they are empty. And if they're full, they're full. And cardiac patients have abnormal hearts. There's all these things, valvular ischemic cardiomyopathy, pericarditis, and a combination of things. And there's preoperative factors. They've either had MIs, had an infarct, they've either got serious valvular problems, they've had pulmonary emboli. So you need a baseline. So whatever that value is that you derive when you do a CVP, it helps you going forward. When I operate on a patient, I want to know what the CVP is prior to induction of anesthesia. Why? Because we want to know what is the patient's status at that time. Because we're also measuring systemic arterial pressure. We're also doing transesophageal echo. So we need a global appreciation of what's going on with the heart. So it's like if you're just going to measure blood pressure and forget about everything else, I think that you are being negligent. So what does it tell you? I've mentioned induction, patients in the operating room, induction, CVP, pre-induction. It tells you about right heart filling at that time, and you correlate with your echo. Post-induction, does it go up or down? It's important. Do you give them fluid or not? Where's Daniel? Same thing. Do you give them inotropes or not? It helps. And the adjunct are transesophageal echo and cardiac output monitoring. And you need to derive values, because I can't just give somebody an inotrope based on a guess, or fluid based on a guess. I have to know the trends, and that's the value. And all of this, you know, preload, contractility, afterload. You need to know all about these things. Frank-Starling curve, we've heard it mentioned. You've got the volume-sensitive side and the volume-less sensitive side. If you've got constrictive pericarditis, your starting CVP is 34. Is that valuable to know it's 34? I think it is, because it also determines your perfusion of your kidneys, because it's back pressure. After your pericardiectomy, CVP is 12. What does that mean? You've done a good operation. So, you know, it's kind of valuable. So we got it all. I can carry on, but the most important thing is we look at SVR in a patient, which is derived value, which you cannot obtain without measuring the CVP. It's all about the trend, not the absolute value. We know all these other things influence CVP. When you say the CVP is unreliable, that's not true. It's the trends that matter. And I've heard some people say, no, they just know. I don't just know after 30 years. I don't. I need to know, and I'm kind of, when you go and say, I used to use a thing called a Swan-Ganz catheter. Has anybody in the room seen it? 2. Okay. We trained with it in the 90s. They use it at Massachusetts General Hospital. Now, all transplant units, you can't transplant a patient without a Swan-Ganz. So I think and it measures RA pressure, it measures PA pressures, RV pressures, wedge pressures, to derive these values to allow you to manipulate your patient's treatment. And it's not just fluid. Thank you.
Okay, so I've got 2 minutes as a rebuttal. Okay, cool. Okay, so I preempted disaster. You didn't mention tamponade, so I'm assuming you mentioned tamponade because normally you'd be able to see with your trends, as Dr. Fulton says, if there's a patient that's going into tamponade post-surgery in the cardiac ICU. Would you take a patient to OT purely based on your CVP reading?
You don't look at just CVP, you look at CVP and lactic acidosis, poor urine output, you go to theatre.
Okay, cool.
Because you don't have time to wait for anybody to come to an echo.
Oh, I'm seeing you're reading very fast. Yeah. Okay, so we do have an echo machine in both of our ICUs. I don't know about the rest of the units. So hopefully that'll help. Oh, I went too fast. Okay, so we also do have other quick tools at our disposal without having a CVP, just in case it's not transduced. You've got instability, hypotension, and then, of course, your narrow pulse pressure, pulses alternates, and muffled heart sounds at your disposal as well, not just CVP. And then cardiac output monitor. You were speaking about SVR being a derived value. So there's a study, I don't know if you can see properly, BMC Anesthesiology put it out, and they spoke about measurements of CVP required to estimate SVR, and it was a retrospective study. So they just wanted to see the feasibility and accuracy of using an arbitrary CVP reading, like they used 5, 10, 15, 25. Arbitrary CVP reading rather than an actual one that's coming off of your patient in real time, and whether that estimation was okay, adequate to be able to then look at your SVR. So they concluded that SVR can be estimated from a fixed value, and they found that 10 is actually not too shabby in your calculation without causing significant deviation or loss of trending ability. So, when I just wanted to go down to this equation here, when you calculate your SVR, you actually take your MAP minus your CVP divided by your cardiac output. And if you talk about MAP, they're quite large values compared to your CVP. So in the greater scheme of things, it doesn't really make so much of a numeric value difference. And then you divide it by cardiac output, and what they found is they didn't have to really have a real-time CVP reading. Almost time. Okay. And then so it was actually higher accuracy, when they just used the fixed value. Anyway, that's interesting. And then that was basically it. Okay, and then you are actually saying that cardiac output reading is better for you than CVP reading. And you spoke about a Swan-Ganz. So, and you said correlate with an echo. So it's always very useful not to just use a CVP. But yeah, thank you.
There is no rebuttal. You need to read the CVP. Like everything else. Unfortunately, I think it's kind of, the idea, what are you going to do? Drop something to get something else. You need everything. And that's simply it. And if you've looked after enough patients, you'll realize there's always going to be a patient that will trip you up. Not all readings are accurate. Cardiac output, no. Cardiac index, yes. Systemic vascular resistance index, yes. Absolute values are meaningless without them being indexed to the patient's body surface area, by the way. But trends are what's important. Whether it's cardiac index, whether it's, when I came to Pietermaritzburg, nobody in KZN used transesophageal echo because everybody just knew. They also didn't use cell savers for what that's worth. But the point is that the standard of care and the ERAS protocols are very clear about what you need to measure. It's so easy to measure it. Why you want to suddenly go to a fixed value, to me, smacks of kind of laziness. Anyway, that's just my opinion.